Bismillahirrahmanirrahim. So, continuing our session with question number 33. So, in question number 33, they are asking about a 67 years old man with mild chronic obstructive pulmonary disease. He is brought to the emergency department by his daughter with chief complaint of seizure. The patient has had episode of confusion and lethargy over the past week. He complains of some exertional shortness of breath and non-productive cough. His daughter believes that he is losing weight and has decreased appetite. His temperature is high and the blood pressure is also his temperature is 37.2 degrees Celsius. Blood pressure is 134 by 88 millimeters of mercury and pulse is 104 per minute and irregular. The mucous membranes are moist and there are no peripheral edema. The neurology examinations are unremarkable and lab studies are as follows. The hematocrit is 34%. Serum chemistry sodium is very low, that is 117 milliequivalents per liter. Potassium is 5.4 milliequivalents per liter, that is within the range. Bicarbonate is 22 milliequivalents per liter. Creatinine level is 1.3. Creatinine level is 1.3 milligram per deciliter. Rapid correction of this patient's metabolic abnormalities puts him at the highest risk of which of the following, and the answer among the following is the option D, that is osmotic demyelination. Educational objective of this question states that acute symptomatic hyponatremia, impaired mental status and seizure is a medical emergency. It requires a prompt increase in the serum sodium concentration with 3% of hypertonic saline at a rate of no more than 0.5 milliequivalents per liter per hour to avoid causing central nervous system osmotic demyelination syndrome. Coming back to the discussion, this patient presents with a provoked seizure in the setting of severe hyponatremia. This is considered a medical emergency and requires prompt correction of serum sodium concentration with 3% saline solution. However, correction of the serum sodium should not exceed 0.5 milliequivalents per liter per hour to avoid causing irreversible brain damage from osmotic demyelination or central pontine myelinolysis. Rapid correction of serum sodium in the setting of hyponatremia result in excess water being moved by osmosis of the intracellular compartment, neurons and glia into the extracellular compartment. This in turn leads to the disruption of cellular metabolic activity and subsequent cell damage. The opposite is true when rapidly correcting the patient with hypernatremia, when cerebral edema can occur. This patient's hyponatremia could be from the lung cancer associated syndrome of inappropriate antidiuretic hormone given his euvolemic status, recent weight loss, and smoking history. The choice B, that was embolic stroke. The embolic stroke was not the option of choice because cerebral edema, actually, the choice A they have discussed already. Cerebral edema will occur if we are correcting rapidly hypernatremia. If hypernatremia is corrected, so there will be cerebral edema, and embolic stroke was not the option of choice because this patient has an irregular heart rhythm, which may be secondary to atrial fibrillation and therefore is at increased risk of an embolic stroke. However, rapid correction of hyponatremia will not contribute to that risk. The choice C, that is hydrocephalus, so it was not the option of choice because the rapid correction of the hyponatremia result in increased water movement out of the brain and so would not contribute to the formation of hydrocephalus. Hydrocephalus can be either obstructive, non-communicating, or non-obstructive, that is communicating, resulting from excess cerebrospinal fluid production or impaired cerebrospinal fluid absorption. Choice E, that is ventricular arrhythmia, this was not the option of choice because the electrolyte abnormalities can result in the cardiac arrhythmias. However, the rapid correction of hyponatremia is more likely to result in the osmotic demyelination in the central nervous system than to cause a ventricular arrhythmia. The next question is question number 34, and they are asking about a 60 years old man. He is hospitalized with multiple generalized tonic-clonic seizures. The patient is a heavy alcohol user and has a previous hospitalization for alcohol withdrawal and alcohol-related seizures. On the second day of hospitalization, the temperature is 37.1 degrees Celsius, that is 98.8 degrees Fahrenheit. The blood pressure is 155 by 92 millimeters of mercury, and the pulse is 108 per minute, and respirations are 14 per minute. Examination shows no abnormalities. The lab studies are shown as follows. The serum sodium is normal, potassium is a bit higher, then bicarbonate level is 20 milliequivalents per liter. The blood urine nitrogen is very high. The blood creatinine level is also very high. The urinalysis shows there is no glucose, ketones are trace, leukocyte trace is negative, and the blood is present, like there is 2 plus presence of the blood. Urine microscopy shows white blood cells 2 to 5 HPF per HPF, and red blood cells 0 to 1 per HPF, and some epithelial cells. Which of the following is the most likely cause of the patient's renal dysfunction? And among the given options, the answer of choice is option F, that is rhabdomyolysis. So, educational objective of this question states that over here, skeletal muscle overexertion, for example, due to tonic-clonic seizures, is a potential cause of rhabdomyolysis, which involves the release of myoglobin into the bloodstream and may cause heme-induced acute renal insufficiency. Heme-induced acute renal insufficiency because urinalysis blood testing detects the heme rather than actual red blood cells. Rhabdomyolysis is often suggested by positive blood in the urinalysis in the absence of RBCs on the urine microscopy. Okay, so positive blood or urinalysis in the absence of RBCs on the urine microscopy. Then the discussion is stating that firstly, we have a table of rhabdomyolysis. Skeletal muscle lysis necrosis due to the etiology is crush injury or prolonged immobilization, intense muscle activity like in the seizure or maybe exertion, and drug and medication toxicity, for example, statins. The clinical features include muscle pain and weakness, dark urine, myoglobinuria, and pigmenturia. The clinical features will include positive blood on urinalysis and no RBCs on microscopy. Then increase serum potassium and phosphate. Serum potassium and phosphate will be increased and there will be a decreased serum calcium and an increase in the AST more than ALT. Acute kidney injury will also be present. Then diagnosis is done by the serum creatinine kinase level of more than 1000 units per liter. It is consistent clinical features. Okay, so diagnosis is made clinically as well with consistent clinical features. Management is done by aggressive intravenous fluid resuscitation and sodium bicarbonate in some cases. So the discussion is stating that the patient with a renal insufficiency and discordant findings on the urine testing, for example, the positive blood on the urinalysis with the negative blood cells on the urine microscopy, following recent tonic-clonic seizure likely has rhabdomyolysis. The rhabdomyolysis involves large-scale skeletal muscle necrosis that can result from crush injury, ischemia, direct toxicity, or in the case of seizures, overexertion from the intense and prolonged muscle contraction. A key component of rhabdomyolysis is the release of myoglobin, a skeletal muscle oxygen storage protein that contains heme pigment into the bloodstream. In the kidneys, myoglobin is degraded and releases heme into the renal tubules that can cause a renal tubular obstruction and tubular epithelial cell injury resulting in the acute tubular necrosis, for example, renal insufficiency. Potassium and phosphorus are also released from the lysed muscle, causing hyperkalemia and hyperphosphatemia. Discordance between the urinalysis, that is rapid dipstick, and urine microscopy blood finding is useful in uh, recognizing the rhabdomyolysis. The blood component of the urinalysis detects the heme rather than actual RBCs. Therefore, the myoglobinuria due to the rhabdomyolysis leads to a positive blood on urinalysis. Because the presence of the heme for myoglobin degradation, in the absence of RBCs on urine microscopy, by contrast, true hematuria leads to positive blood in urinalysis and presence of RBCs on the urine microscopy. So the choice A, that was acute interstitial nephritis, it was not the option of choice because the acute interstitial nephritis involves the renal inflammation, typically evidenced by the positive leukocyte esterase on urinalysis and elevated WBC, and with the WBC cast on urine microscopy, the patient's urine WBC are within normal limits. The choice B, that is glomerulonephritis, it was not the option of choice because in glomerulonephritis, it is characterized by the RBC passing through the glomerular membrane to cause true hematuria. Dysmorphic RBCs and RBC casts are expected on the urine microscopy. Then choice Charlie, that is about the hepatorenal syndrome. Hepatorenal syndrome was not the option of choice because in hepatorenal syndrome, it can occur in the patient with the advanced liver disease. It results from the vasoconstriction of the renal arterioles, causing the pre-renal injury with an expected blood urine nitrogen creatinine ratio of more than 20. So, if there is expected blood urine nitrogen to creatinine ratio of more than 20, then we expect hepatorenal syndrome. Positive blood is not expected on urinalysis. Then option D, that is over here. So option D, that is nephrolithiasis, it was not the option of choice because the nephrolithiasis is a common cause of true hematuria. In addition to positive blood on urinalysis, numerous RBCs are expected on the urine microscopy. The choice E and G, that is renal artery stenosis and urinary tract obstruction. So renal artery stenosis and none of them were the option of choice because both urinary tract obstruction, for example the benign prostatic hyperplasia, and the renal artery stenosis can cause renal insufficiency. However, the rhabdomyolysis is much more likely in this patient given his recent seizure and his coordinate blood findings in the urine testing, which would not be seen with the urinary tract obstruction or renal artery stenosis. Question number 35, we are asking about a 42 years old man comes to the office due to non-pruritic, non-painful skin lesions on the left upper arm that began 2 months ago. He has also tingling and numbness of the left fingers. The patient has no medical history and does not take any medication. He emigrated from the Southeast Asia to Connecticut a year ago. Temperature is high. The blood pressure temperature is 36.6, that is 97.8 degree Fahrenheit. The blood pressure is 126 by 82 millimeters of mercury and pulse is 74 per minute. Skin examination shows a 4 cm well circumscribed hypopigmented patch on the left upper arm with no sensation to pinprick. The ulnar nerve is thickened and tender at the left elbow. Okay. The touch and pain sensations are absent in the left ulnar nerve distribution. Which of the following is most likely to confirm the diagnosis in this patient? And the answer among the following options is option delta, that is skin biopsy from the edge of the lesion. Educational objective of this question is stating that the leprosy is a chronic granulomatous disease of the skin and peripheral nerves that is found primarily in the developing regions. Symptoms include the chronic anesthetic hypopigmented lesions with a peripheral nerve involvement, that is nodular painful nerve deformations and diminished sensory and motor activity. Diagnosis usually requires a biopsy from the active edge of the lesion. The table of the discussion is stating about leprosy epidemiology. Mycobacterium leprae is the causative agent, primarily in the developing world, for example, Asia, Africa, and South America. Respiratory droplets, 9-banded armadillo, and low infectivity. Then manifestations are macular anesthetic skin lesions with raised borders, nodular painful nearby nerves with a loss of sensory and motor function. Diagnosis: full thickness biopsy of the skin lesion, that is active edge, and Mycobacterium leprae is not culturable. Treatment is dapsone plus rifampin and clofazimine if severe, that is multibacillary. Leprosy is a chronic granulomatous disease of the skin and peripheral nerves caused by the acid-fast bacillus Mycobacterium leprae. Transmission is thought to occur via respiratory droplets, although cases are occasionally linked to close contact with a 9-banded armadillo. Infections are rare in the United States and occur primarily in the immigrants or travelers to endemic regions, for example, Asia, Africa, and South America. Manifestations include more than equal to one chronic anesthetic, macular, often hypopigmented, skin lesions with raised, well demarcated borders. Nearby nerves often become nodular and tender, and segmental demyelination may result in the loss of sensation and motor function. Diagnosis is clinical if endemic regions in the endemic regions, but in the United States usually require a full thickness biopsy of the skin lesion edge, as Mycobacterium leprae is not culturable. Patients with the minimal lesions, for example, paucibacillary, minimal lesions like paucibacillary are treated with a dapsone and rifampin. Those with the extensive lesions, that is multibacillary, require the addition of clofazimine. Lesions often take months or years to heal completely. The choice A, that is anti-Borrelia burgdorferi antibody assay, it was not the option of choice because Lyme disease typically manifests with the erythema migrans, a slowly spreading erythematous lesion with a central clearing that is called the bull's eye lesion. Sensory or motor neuropathy may sometimes occur in early disseminated disease. Nerve thickening and tenderness with an anesthetic lesion are more likely to indicate the leprosy. Choice B, that is KOH preparation of skin scraping. It was not the option of choice because the KOH scraping can diagnose the dermatophytes, for example, the Tinea corporis and Candida albicans. Tinea corporis causes ringworm, which manifests as a pruritic scaly plaque that spreads centrifugally. Scaly plaque that spreads centrifugally, leaving a cleared center. Anesthesia, nerve nodularity or pain, and paresthesias are not typically a feature of these fungal infections. Choice Charlie, that is nerve conduction studies. This is not the option of choice because nerve conduction studies are likely to be abnormal, that is decline in the conductive velocity, but would not provide a diagnosis. A skin biopsy is required for the diagnosis. The choice eta, that is treponemal serologic testing. It was not the option of choice because the primary syphilis is characterized by the painless chancre, that is shallow, non-purulent ulcer with a raised, well-demarcated borders. Tertiary syphilis may cause skin gomas, soft ulcerative masses with necrotic centers. Neither primary nor tertiary syphilis is commonly associated with a localized anesthesia or nodular peripheral nerves. The choice F, that was tuberculin skin testing. It was not the option of choice because Mycobacterium tuberculosis can rarely cause skin manifestations including ulcers, nodules, and watery plaques. A hypopigmented anesthetic patch with a nerve nodularity pain is more likely to be leprosy. Then question number 36. A 65 years old woman who recently relocated after retiring comes to the office to establish medical care. The patient has a history of hypertension, type 2 diabetes mellitus, hyperlipidemia and osteoarthritis. She does not monitor blood pressure at home and reports fair glycemic control with oral anti-diabetic medications. The patient does not use tobacco, alcohol, or illicit drugs and formerly worked as a salesperson in a departmental store. The blood pressure is 138 by 76 millimeters of mercury and the pulse is 82 per minute. The BMI is 34 kg per meter square. The cardiopulmonary and abdominal examinations are unremarkable. The foot examination reveals her third and fourth toe appear claw-shaped, with dorsiflexion of the uh, proximal phalanges at the metatarsophalangeal joint and the palmar flexion of the proximal and distal interphalangeal joints. Which of the following is the most likely cause of the patient's lower extremity findings? Among the following options, the option of choice is diabetic neuropathy. Educational objective of this question is that claw toe deformity, the claw toe and hammer toe deformities reflect an imbalance in the strength and flexibility between the flexor and extensor muscle group. Between the flexor and extensor muscle groups, in a patient with long-standing diabetes, these deformities may suggest an underlying diabetic peripheral neuropathy. Other complications of diabetic neuropathy include callousing, ulceration, joint subluxation, and Charcot arthropathy. Coming to the picture, here you can see that it is a hammer toe or claw toe deformity. In the hammer toe deformity, there is dorsal flexion at the distal interphalangeal joint and dorsal flexion at the metatarsophalangeal joint. This something is called as a hammer toe. Then the claw toe is dorsal flexion at the metatarsophalangeal joint and plantar flexion at the proximal interphalangeal and distal interphalangeal joints. Here we have the plantar flexion at the proximal interphalangeal joint only, and at the distal interphalangeal joint and the metatarsophalangeal joint we see the dorsal flexions. Okay, so the patient has a claw toe deformity characterized by the dorsiflexion at the metatarsophalangeal joints and the plantar flexion at the proximal and distal interphalangeal joints. The claw toe and hammer toe similar to claw toe but with dorsiflexion at the distal interphalangeal joints. Deformities are common in elderly patients and reflect an imbalance in strength and flexibility between the flexor and extensor muscle groups. These deformities are often due to simple mechanical problems such as chronically ill-fitting shoes, but in the patient with a long-standing diabetes, they may suggest underlying diabetic peripheral neuropathy. The etiology of the foot deformities in the patient with a diabetic neuropathy involves multiple factors including arthropathy of intrinsic foot muscles due to degeneration of the motor axons, decreased pain sensations and proprioception, and concurrent orthopedic and vascular disorders. Long-term complications of diabetic neuropathy include callousing, ulceration, joint subluxation, and Charcot arthropathy. Bone and soft tissue destruction and deformity can also be seen. Then the choice B, that is foot osteoarthritis. It was not the option of choice because the foot osteoarthritis, symptomatic osteoarthritis of the foot usually involves the midfoot and the first metatarsophalangeal joint. Involvement of the lesser toe is much less common. The choice Charlie, that is motor neuroma. This was not the option of choice because the interdigital Morton neuroma or Morton neuroma is mechanically induced neuropathic degeneration of the interdigital nerves. It presents with a numbness or pain at the distal forefoot between third and fourth toes. It does not cause significant deformity and gross inspection of foot is typically normal. The choice delta, that is plantar fasciitis, it was not the option of choice because plantar fasciitis is characterized by the collagenous degeneration at the insertion of the plantar fascia on the calcaneus. It presents with a heel pain that is worse when standing on the hard surfaces, especially with the first step of the day. The choice eta, that is spinal stenosis. So spinal stenosis is not the option of choice because The spinal stenosis is an abnormal narrowing of the spinal canal, compression of spinal canal. Compression of the associated nerve results in lower extremity pain, numbness, paresthesia, and weakness that are worse with the extension of spine, that is walking upright. Next question. So these are some links where you can find a lot of stuff. So the next question is question number 37. In question number 37, they are asking about a 68 years old man comes to the office with a 2-day history of right foot pain and swelling. The pain started acutely when he woke up in the morning. Initially, the patient had pain only on the dorsiflexion of the foot, but he progressively developed pain with any movement at the ankle or weight bearing. The patient has not had similar symptoms before. He is normally very active and has spent a week bicycling in Utah for 3 weeks prior to presentation. The medical history is notable for type 2 diabetes mellitus, hypertension and hyperlipidemia. Temperature is high and the blood pressure is 140 by 90 millimeters of mercury and pulse is 90 per minute. Examination of the right foot shows warmth, swelling and tenderness over the dorsal surface of foot, okay, and around the right ankle, but both dorsiflexion and plantar flexion are restricted due to pain. The skin is intact without ulcers or break. Pulses are full and equal in both the feet and sensory sensations are normal. X-ray reveals soft tissue swelling, similar small tibio-talar joint effusion and chronic calcification of the articular cartilage. There is no fracture or dislocation. Which of the following is the most likely diagnosis? And the answer among the following options is option beta, that is calcium pyrophosphate arthritis. Educational objective of this question is stating that the finding of the chondrocalcinosis in a joint with a typical acute inflammatory arthritis establishes the diagnosis of probable calcium pyrophosphate dihydrate crystal arthritis or pseudo gout. Synovial fluid analysis will show an inflammatory effusion and rhomboid shape, weakly positively birefringent CPPD crystals. The table that is present in the discussion: pseudo gout, acute calcium pyrophosphate crystal arthritis symptoms, acute mono or oligoarticular arthritis, peripheral joints, knee is the most common. Diagnosis: inflammatory effusion of 15,000 to 30,000 cells per millimeter cube. The CPPD crystals, rhomboid shape, positive birefringence, and chondrocalcinosis will be seen on imaging. The treatment is in intra-articular glucocorticoids, non-steroidal anti-inflammatory drugs, and colchicine. This patient has characteristic findings of acute calcium pyrophosphate dehydrogenase crystal arthritis (CPPD), crystal arthritis or pseudo gout, including onset of age more than 65, monoarticular arthritis, and chondrocalcinosis, calcification of the articular cartilage. Synovial CPPD deposition can also cause a chronic inflammatory arthritis, establishing arthritis resembling the rheumatoid arthritis and a non-inflammatory degenerative process resembling the osteoarthritis. Pseudo gout commonly affects the knees and ankles, where it may be difficult to distinguish from the urate gout. But it also frequently affects the large joints of the upper extremity and may involve multiple joints concurrently. Attack of the pseudo gout often occur in the setting of trauma, overuse, surgery, or medical illness. The finding of the chondrocalcinosis in a joint with a typical acute inflammatory arthritis establishes a diagnosis of probable CPPD crystal arthritis. Synovial fluid analysis will show an inflammatory effusion of 15,000 to 30,000 cells per millimeter cube, along with a rhomboid-shaped, weakly positively birefringent CPPD crystals. Arthrocentesis of the synovial fluid analysis is advised to exclude the urate gout up to 50,000 cells per millimeter cube. Needle-shaped, negatively birefringent urate crystals are seen in the gout with a urate crystal deposition, and septic arthritis that is more than 50,000 cells per millimeter cube visible organisms on the gram stain. Choice A, that is bacterial infection of the ankle joint. It was not the option of choice because the risk of septic arthritis is higher in the joints injured by other conditions including the gout and pseudo gout. However, septic arthritis is usually associated with a fever and other systemic symptoms and arises from hematogenous spread following the trauma. Chondrocalcinosis on X-ray is more suggestive of pseudo gout. Then choice Charlie, that is monosodium urate arthritis. So monosodium urate arthritis, urate gout has significant overlap with pseudo gout in the clinical features and may also affect the ankle. However, the urate gout is not associated with the chondrocalcinosis. The choice Delta, that was neuropathic pain. It was not the option of choice because the neuropathic or Charcot arthropathy causes destructive arthritis in the patient with a long-standing diabetes who have no peripheral neuropathy. Although ankle is commonly involved, obvious deformities and chronic pain are characteristic. The choice eta, that is plantar fasciitis, it was not the option of choice because the plantar fasciitis causes subacute to chronic pain on the plantar surfaces of hind foot. Inflammatory features are absent, and the tibio-talar joint is not involved. The choice F, that was the stress fracture. So this was not the option of choice because the metatarsal stress fractures can be seen following strenuous activity and may be undetectable on initial X-ray. However, there is they are usually not associated with the joint pain or chondrocalcinosis. The next question we will discuss in the next session. Until then, Allah Hafiz, Fi Amanillah, and take care.